We move on to a clinical subject of early CKD management and its essentiality in type 2 diabetes management, because we no longer talk of only glycemic control. We talk of improved cardiorenal outcomes. So to deliver this important talk, we have with us Dr. Dheeraj Kapoor, who is Head of Endocrinology and Diabetes Services at Artemis Hospital, Gurugram. Besides being an astute clinician, a very avid researcher, writer, very energetic speaker, practically will be seen in any conference in NCR. And over to you, Dheeraj. Please carry on.
Thank you so much, sir, for that generous introduction. I'll try to prove myself worthy of what you said a little while back. So I'll start with a very blunt statement. High blood sugar levels don't kill anyone. Cardiac diseases and nephropathy do. And therefore, the approach is now from glucose-centric to a holistic approach. Although the word now that I used is a slight misconception, because steno trial has shown long back. Now that we are in the era of gliflozins, yes, it has now gained momentum, but steno trial was the one to show that let's not be glucose-centric. So this would be my scheme of doing things. Now, if you diagnose CKD earlier, the better it is. And I'll have data to show that, just a slide in there. The first stage is hyperfiltration, and therefore on ultrasound, if a long-standing diabetic patient has a normal-sized kidney, you should always look at it with suspicion, because hyperfiltration causes enlarged kidneys slightly. So CKD, well, 11.1% of global population, and the INSIGHT CKD has shown that the numbers will shoot up dramatically. But we know that the figures that are projected are being achieved much earlier because of the speed that the pandemic is gaining. Now, to your left is the slide which shows that we have improved in mortality on all fronts. May it be ischemic heart disease, may it be stroke, may it be COPD, it's a detour, but this is just to highlight that CKD is still on a rising trend, albeit slowly. Yes, the monitoring and diagnosis also has increased, because we are ordering UACR in almost all our diabetic patients. That's besides the point. But the fact of the matter is, so have other specialities. So 1.2 million deaths in 2016 and supposed to double by 2040. Now, CKD in India, high prevalence, 17.2, which means 1 in almost 6 people have it. The most prevalent is stage 1, and progression is quick. And we have around 2 lakh patients on dialysis across India, and these include only the ones who are being treated. Those in the villages who cannot get access to good care may be much higher. So KDIGO recommends screening of high risk groups, which include hypertensives, diabetic patients, and those with cardiovascular disease. And I read verbatim what they have said: a strategy of CKD screening in populations with common and important CKD risk factors will help identification priority of patients at high CKD and CV events. And we know that nephropathy is a risk for CV event, because nephropathy signifies some kind of endothelial dysfunction at the level of glomerulus, and therefore nephropathy may actually be a marker of high risk CVD. Now, this is the slide I was referring to. Reveal CKD, 27,000 people studied, and this showed that if they were diagnosed earlier, the risk of progression went down to 0.3 from 4.1. So this is the importance, and the logic is clear. The earlier you diagnose, the earlier you intervene, and of course the patient also becomes conscious of the fact that he has a problem. So if you do not intervene, well, possibly 7 years is the median time for things to happen. If you intervene 4 years after diagnosis, you probably prolong. And if you intervene around 2 years of diagnosis, you further prolong the nephropathic agony of the patient. Now, this is an age-old slide. We are all aware. A1 and G1, G2 are very, very good. But anything beyond G3 or anything in A3 is in the red, which means it is very high risk. Now, you have to consider EGFR and UACR in all your patients. Earlier, it was said males creatinine more than 1.5, females more than 1.4. Fair enough. But imagine an 80-year-old lady, 40 kilograms, creatinine of 0.9. She doesn't have a good GFR despite creat being less than 1.4. On the contrary, 85 kg male, 40 years, creatinine 1.6, he will still not have ESRD. So GFR is paramount. Yes, creatinine may be a poor man's marker for nephropathy. So intensive control might not mitigate the risk totally. So if you control the blood pressure, the lipids, the glycemic control, maybe antiplatelet drugs, you reduce things by 44%, but still there's a residual risk, and that is the risk we have to address. So there could be an element of poor glycemic control, poor BP control, and that unknown, possibly the fibrosis. And fibrosis may apparently be addressed by drugs like gliflozins and drugs like finerenone and spironolactone. So it is important that think beyond glucose. I fully accept that the patients are still glucocentric, and amongst glucocentric, they are fasting blood sugar centric. But nonetheless, we on our part have to act early to prevent CKD. So what are the guidelines? Well, I still am a huge fan of metformin. Yes, gliflozins may take precedence in those with established CVD and if metformin is contraindicated, but you have to give metformin at all GFRs till 45. If the patient is not on metformin, do not start below 45. Below 45, reduce the dose. Below 30, stop metformin. And obviously, during dialysis, the question does not arise. Of the renoprotective drugs, gliflozins, if for some reasons they can't be taken, then GLP-1 analogs, and as Deepak was talking about linagliptin in his previous talk. So, two aspects, CKD with albuminuria and without albuminuria. So, CKD, you may use gliflozins. They reduce progression. I'll be showing data that they might possibly go to the backstage. I'm not using the word reversal because reversal would send different connotations and misconceptions. So conversion to a lesser stage. Then you may use gliflozins for reducing CKD in a patient who already has CVD. We have data that there's a cardio-renal continuum that is working. And of course, if you can't give CKD, can't give gliflozin, you use GLP-1s. The reason therein is repeated GTIs. We have published a data in IJEM wherein we showed 21% GTIs in patients on gliflozins. And this was despite the fact that we explained very clearly about hydration hygiene. And the drug was stopped, things recovered, restarted again 15%. So chances are high. In those cases, you could use, and in those patients, CKD without albuminuria, you could use either of them. Now, which SGLT2? Well, it's a different question. I'll be going into DAPA CKD because DAPA and EMPA were the ones which used non-diabetic population as well. That's why I'll be going there. Nothing to take against credence. But for paucity of time, I'll be refraining from credence. So EMPA-REG, we know the population. EMPA-REG, primary prevention, canvas, primary, secondary. DAPA, the garden variety of patients that we see daily in our OPD. And this is that if you use gliflozin, the risk goes down. Now, DECLARE had good data, 47% reduction in patients with outcomes. And these patients had much better GFR as compared to those with CANA and EMPA. Now, this benefit was shown across GFR groups and across CBD risk groups. Less than 60, well, numerically much better, but just cross the midline there, 1.02 is what we're talking about. So less than 60, not superior statistically, but numerically it was superior. Now, as regards the CBD and multiple risk factors, this was the trial which showed multiple risk factors. So again, benefit established. Now, this is the trial that we need to see, that possibly it could erase the metabolic memory to a certain extent. So, from normal or micro to macroalbuminuria, or normo progression, or eventually to micro, across all spectrums, you see that rectangle well to the left of the line of unity, which actually confers superiority. And this is even better, regression, not reversal, regression. So not only does it prevent progression, but can also cause regression of albuminuria. One thing should be clear, that if you start these gliflozins, there may initially be a fall in GFR and a consequent possible rise in creatinine, but that should not deter us, because if you see the slope, no patient on gliflozin, it will go down slowly, but downhill course. Here, in gliflozin, the curve goes down and then eventually returns back to the normal. So, evidence, DAPA CKD, 4,300 patients, GFR up to 75, it was up to 90 in CANA, USCR. These people gave DAPA even on dialysis. I'm not too sure why they did that, but possibly to prevent the cardiac mortality because the kidneys have already been knocked off. So that was the possible logic. Below 60, we've seen they don't work as good glycemic agents. So possibly the logic could have been cardiac. The cause of kidney disease was 58% diabetic patients. The outcome, 39% reduction in GFR, renal death, so on and so forth. All-cause mortality, 31%, and composite of CV and heart failure, 29%. Now, these were the patients who were relatively healthy. They may not have had established heart disease. Now, this data shows that they even work better in non-diabetic patients. In fact, IgA nephropathy also, it has been shown to have benefit. IgA nephropathy, where many treatments are not available. So, DAPA and EMPA, 39% versus 28, all-cause death lesser in DAPA, composite CV less again in DAPA, all-cause hospitalization in both the groups, they were good. So, what about the other agents? So you see the gliflozins right on top as far as the renal protection is concerned. We have a new kid of the block, that is finerenone, but finerenone is even below GLP-1s. Yes, there is encouraging data from both the Fidelio and the Figaro trials. I'm not denying that. And possibly one mechanism therein is reduction in fibrosis, because we know that these drugs, both at the level of myocardium and at the level of kidney, are anti-fibrotic agents. So, to summarize my talk, we know that CKD is highly prevalent but underdiagnosed. Microalbuminuria, which is now called a moderate progressive albuminuria, is the first clinical stage where you can diagnose. Otherwise, the other definition is class 3, which means GFR below 60. Most guidelines recommend early use of gliflozins, particularly in patients in whom you want to prevent CKD, who have established CKD, in those who want to achieve weight loss, because we know that 3 kilograms of weight gain nullifies the benefit accrued by 1% fall in HbA1c. Gliflozins provide good protection of spectrum of renal protection, and dapagliflozin has been used in garden variety of patients with PC, so that could be a robust tool. Thank you so much for your attention.
Thank you, Dheeraj, for that very illuminating and energetic presentation. Very crystal clear, messages driven home, clear and hard.